Ma'am, with your permission, shall we start?
Yeah, sure. Yeah. Yeah, I'm ready.
Thank you. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we will have a short Q&A session. So let me welcome today's our eminent speaker, Dr.Sai Lakshmi Dhyanan, ma'am. We are very honored to have you, ma'am, for today's webinar. She is graduated from Usmania Medical College, Hyderabad. Following this, she pursued her higher degrees in Ops and Gynecology and Gynecological Oncology in UK, MD from University of Manchester, and subspecialty training in gynecological oncology. She trained and worked in UK for almost 18 years. Her last post was as a consultant in surgical gynecological oncology for 3 years at St. James Institute of Oncology, Leeds, UK. Since she has moved to India in September 2016 and has taken up the post of consultant surgical gynecological oncology at Apollo Institute of Cancer, Hyderabad. Dr. Sai Lakshmi Dhyanan ma'am is a cancer surgeon and is experienced at performing open, laparoscopic, and robotic procedures for gynecological cancers like ovarian, uterine, cervix, vagina, and vulva. She is also a trained gynecologist with 20 years of experience and is an expert in dealing menstrual problems, pelvic pain, and menopause issues. She is ardent about promoting women's health and well-being. She has taken interest in making women aware about cancer screening options and risk-reducing options. She is also an excellent health and well-being counselor. So with this, we welcome you, ma'am, for today's webinar on worsening of common gynecological problems during COVID. So over to you, ma'am.
Thank you so much, Som. That was a very kind introduction, I have to say, and a very warm welcome and good evening to all my gynae colleagues. Today's topic is rather interesting. It is what's happening to our obs and gynae problems, mainly gynecological problems during this COVID pandemic. And we have all significantly changed the way we practice since the pandemic. And is this change because we want to change, or is this change because we are forced to change? Is different. Given a choice, we would much rather go back to how we were prior to March 2020. I would do anything to go back, rewind my life 1.5 years ago, and go back to being normal again. But unfortunately, we can't do that. And so much has changed about how we practice, the way we deal with patients, and we have observed that a lot of our patients have come to harm because they haven't been able to come to the hospital. We have changed the way our practice, but still we are seeing quite a lot of health issues since the pandemic in ops and gynae. But then there are some learning points as well. During this journey, we learned that we don't need to do things the way we were always doing. There are certain things the pandemic has taught us about how to do things differently in future. And we thought we'll just focus a little bit about what this COVID has done to ONG patients. And one thing it has certainly done to me is I was doing 90% gynae oncology and maybe 10% benign gynae work. And now it's turned the other way around. So much of my work these days is focused on telecommunication, on virtual medicine. We're doing so many online appointments and very few actually real appointments. So much of the online consultation is all about benign gynae, early pregnancy, and so on. We'll come to it. I'll start looking at the slides. Me and Dr. Som prepared. And can just one of you confirm that you can see the slides?
You can't see any slides, actually.
You can't? The practice thing worked. What happened? It was working earlier. You can't see anything at all?
No, ma'am.
Okay, one second. What could have happened? Okay, just bear with me. Can you see it now?
Yes, ma'am. Now we can see. We
Yeah.
can full screen. Yeah. Thank
Yeah. So, like I said, if at any stage there's an issue with the slides, please someone tell me. And it literally feels like I'm talking to a computer screen, and it's so weird doing this. Anyway, worsening of common gynecological conditions, and I'm sure you all agree with me. And at any stage, if there is a comment you have to make or something you want to share or something, this is all a learning experience for all of us. And if you feel like in given a scenario like this, you dealt with it differently, you did something different which actually could be learned by others, please do interrupt and leave a comment. And Dr. Som, please do let us know if someone's sharing an interesting comment. I wouldn't mind you interrupting me, because I think this is all a mutually learning experience by all of us. This pandemic situation is new to all of us. And we all know that health is not just physical health, but there is something called emotional health, mental health. And a lot of us are going through this phase where we don't feel healthy. Physically, we might be healthy. Physically, we might be COVID free. Physically, everything might be okay with us. But if you today asked me, if you said, Sai, are you okay? Or do you feel healthy? And I would say, no, I'm not. Actually, I'm not feeling healthy at all. I haven't been feeling healthy for months. There is this state of sadness, a bit of feeling low, a bit of feeling useless sometimes, a bit of disappointment in life. It's like, where's this pandemic taking us? What's happening with us, with our personal lives, the people who we have lost? I lost my father to COVID, and things like that. Where's my career going? It's nearly a year and a half, and looks like we have gone backwards in our career. So all this is taking a toll on my mental health, on my emotional health. And so according to the WHO definition, I don't feel healthy at all. What about our patients who seek appointments with us, who are not able to approach us? It's our responsibility to make sure they're as healthy as possible during these difficult times. And we have to remember that sometimes health is not just the physical health and not just the gynecological health. Some people keep on taking the teleconsultations, and you think only 4 days ago I spoke to you, or the window period after a teleconsultation is open for a week, where they can keep chatting with us and communicating with us. And every day there is some message, some message which is not actually relevant. Doctor, will I be okay? Or I took the medicine and I'm feeling better. And then you realize that these people actually just want to talk to somebody. You think I might not have time to keep on chatting with these people, but that's what you realize, that sometimes some people need a little bit of extra hand holding. That is what they're trying to get from us, that little bit of communication and reassurance. Maybe they're all feeling a bit low and worried and anxious. Moving on to one of the commonest problems which young women these days are facing. What's happening to all these PCOS patients during this pandemic? What I notice is the PCOS is worsening, or there are a lot more PCOS patients during the last 1 year than I have known in the past. And I thought, is it just me imagining? Why is every alternate consultation about PCOS? And there have been papers, there are almost 100 papers in the last 1 year which have been telling us that the PCOD in the pandemic is on the rise. And it's very easy to understand why. People are sitting at home, they're working from home. There's no food from outside, there is no traveling, there is no wasting time going from point A to point B. You're just home 24/7. So what else do people do? They just sit and eat. So this is plenty of an opportunity to sit and eat and get even bigger. The gyms are closed. That doesn't stop people from going for a walk. Does lockdown mean you can't go for a walk in your street? No, it doesn't, but people still don't leave the home. They are at fear of getting the virus from somewhere. And people are just sat home, not exercising. The gyms are closed. There is no social activities anymore. There is no going to the clinic where the doctor or the nurse will motivate you to become someone better. And the PCOD is on the rise. And then the medication, PCOD medication is not just something you prescribe and say, go take it. You put them on the pill, you put them on metformin, you put them on the inositols, and then you send them to the dietitian, you send them for physical exercise training. And where is all that happening? How can you justify a PCOD consultation on a telephone conversation where you can't see the person properly, you can't communicate properly? And undoubtedly, the PCOD problem is on the rise. And obviously, PCOD is not just PCOD. PCOD means period issues. PCOD means skin problems. PCOD means hair problems. PCOD means subfertility. PCOD means endometrial thickening and future endometrial problems. So this PCOD, which is on the rise in the pandemic, is going to cause a lot more problems over the next few years to these ladies. And as gynecologists, what can we do for these PCOD patients? And what I tell them is, this is an opportunity to actually lose weight. All these days, you were telling me you were very busy studying, you were very busy working, and you never got time to do anything. Now, you might still be studying and you might still be working, but you're almost saving 2 to 3 hours a day where you're not commuting, you're not going anywhere, you're not spending the time in traffic. Use that to eat healthy and exercise more. And I tell them, if you're home with all this free time and you're still not losing weight, it's a shame on you. So it's kind of pushing them a little bit harder and telling them that they can and they should try and lose weight, which in fact will help their PCOD. So all this extra time people are getting is actually doing the wrong thing, which is making them put weight on. And I think we as doctors can do that little bit of extra motivation. What did we do for abnormal uterine bleeding in the non-COVID times? If, say, last year, January, someone came to us with abnormal uterine bleeding, obviously we would follow the Palm and Cohen algorithm. The first thing we would do is a very decent history taking. When is this bleeding happening? How much? How often? In between periods, with periods, whatever. So a thorough history can also be taken during a teleconsultation. That's not an issue. But as a gynecologist, I never ever not do a speculum and a bimanual examination on my patients. And I'm sure you all as well examine the patient when they come with abnormal uterine bleeding. And that is not happening. Without a proper examination, how do you know that there is no cervical lesion? How do you know that there is no polyp protruding out through the cervical os? How do you know that there are no lesions on the vulva or the vagina? How do you know the size of the uterus? Is it so important to know these things? Sometimes it is important, but we are not able to do that. Following that, depending on the history, depending on what we think this diagnosis could be, we would do the blood test if necessary, a CBP, TFTs in young patients with menarche issues and prolonged bleeding. We might do a coagulation, which we can still do online. I've picked up a lot of thyroid abnormalities during this pandemic when I do teleconsultations. People come to me with period problems, you do their thyroid test and it's abnormal. Pelvic scan, again, one of the things we very often rely on for abnormal uterine bleeding, especially when we suspect endometrial hyperplasia or endometrial polyps. But these days, asking a woman to go for a pelvic scan and looking at that report during a teleconsultation is almost impossible. People want you to give medicines, but they don't want to go out for scans. They don't want to come for an examination. What about PAP? When did you last do a PAP on a patient during this pandemic? What about hysteroscopy? What about endometrial biopsy? If I see a woman with thickened endometrium, she's finished her family, I will do an endometrial biopsy and insert a Mirena at that opportunity if I don't think there is a cancer. Am I able to do that in the pandemic? What about if there is a polyp in the uterus? We would go for a polypectomy. What about a hysterectomy for that really bad case of endometrial polyps, adenomyosis, and so on? What's happening to all of this in this pandemic time? How much of this are we able to do? And by not doing what we normally do, what are we missing? So during COVID times, we do take a history, we do the blood tests, and if you're fortunate and the patient agrees for a pelvic scan, you will get luckily a scan. A patient consults me yesterday and the scan report she uploaded is from 2013, which is 9 years ago. And I'm asking her, what do you want me to do with your report, which was 9 years ago? And she tells me, she asks me yesterday, this happened yesterday, can't you see my scan report from then and treat me now for my period problems? You know, that's how people are sometimes. So luckily, if you are lucky, you might get a pelvic scan just by a history taking. How much can you treat an abnormal uterine bleeding? And what if that bleeding is due to a polyp or a cancer? Where do these people go from here? And this is what is being missed in this pandemic time. Some diagnosis is getting missed, some treatments are getting missed. People are bleeding, sat at home, becoming anemic and getting more unwell. What about pelvic pain in COVID times? Obviously, a thorough history will almost always help you differentiate between pain due to urinary tract, pain due to intestinal tract, and pain due to the pelvic organs. The pain could be renal stone, the pain could be an ovarian cyst. This is where the history of vomiting and feeling of dizziness associated with pain might help. The pain could be due to adenomyosis, it could be endometriosis, could be PID, and often, especially to differentiate a renal stone from an ovarian cyst to that of an endometriosis or adenomyosis, in addition to the history, we bank on a decent pelvic ultrasound scan and an abdominal scan. And again, that might be a difficult thing to do in the pandemic. And therefore, your history taking becomes even more important. Abnormal vaginal discharge. A lot of teleconsultations these days are for vaginal discharge, white discharge. If the white vaginal discharge is the moment, the first question is, okay, is this discharge white like curd? And if the answer is yes, I'm already very happy. And if I say, is there any irritation or vaginal itch? And the answer is yes, I'm a super happy woman because then I can treat her happily for vulvovaginal candidiasis and I don't need to really rack my brain too hard. But if the woman says, no, there is no itching or it's not like white and curdy, then you start to think, goodness me, what could this be? Then you start to ask about odor. Is there a fishy smell? Is there a dirty smell? And almost every woman says, it's not dirty, but there is a smell. At the end of the day, I can smell it. What do you make of it? What is a dirty smell? A dirty smell to you might not be dirty smell to me and vice versa. So often, if the diagnosis is not a clear-cut vulvovaginal candidiasis, it starts to worry me. It's like, what if I'm missing a chlamydia or a gonorrhea infection? What if it is bacterial vaginosis? Every time I do a speculum examination and there is froth in the vaginal discharge and the woman complains of vaginal irritation, then I'm thinking this is BV. And majority of the times my diagnosis is correct because that clear-cut frothy discharge is almost always due to BV. I immediately put the woman on metronidazole even if I send a swab because majority of the times it does come back as BV. But how do you do that on a teleconsultation? How can you diagnose bacterial vaginosis? So if the woman is telling me there is no curdy white, there is no itching, but there is excessive vaginal discharge, then do I assume it's physiological? Do I assume it is bacterial vaginosis? Shall I just give this woman week-long antibiotics of clindamycin, blah, 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 thinking this is BV? Is that unnecessary course of antibiotic going to do her harm or good? How do we know? So we end up giving a lot more antibiotics because we are not able to see this woman. And those lot more antibiotics will definitely make this woman consult you again for vulvovaginal candidiasis about a week or 10 days later. So this is a vicious circle. You don't know what you're treating, why you're treating, when you're treating. And if at all the woman says there is some blood in this discharge, and yes, it's sometimes after intercourse, my heart sinks because it could be cervical cancer, it could be a lesion, a lump on the cervix, and how do you know it is not? A question regarding when was the last pap test almost always reveals the same answer. What is a pap test? So this woman never had a pap test. How do you convince this woman who has called you for vaginal discharge to come to your clinic for an examination for a cervical cancer to be ruled out is impossible. You tell them that, look, if you don't get better with this treatment with Fluca and Candid, you might have to come to the hospital for us to make sure that it's not a cancer. They think this woman is trying to scare us. She's just trying to bring us to the hospital. And then they go, it's Corona time. How do you want us to come? How can I come? So the vaginal discharge in this pandemic time is a nightmare to treat unless it's a clear-cut candidiasis. Moving on to unwanted pregnancies in COVID times. I think the unwanted pregnancies have just gone up tremendously, and there are numerous papers from all over the world, Middle East, South America, Europe, everywhere there faces issue of unwanted, increase in the number of unwanted pregnancies. And obviously the reasons are so obvious, we don't even need to discuss and try and figure out what the reasons are. In addition to people staying home and spending a lot of time together, one of the things is not a lack of availability of contraception. Well, maybe these people would have come to the hospital for a prescription for the pill. Maybe they would have gone outside to buy some condoms, but now They don't leave home. They're frightened of contracting the virus, or there is nothing open for them to go and get the pill or the condoms. People take the risk, they get pregnant, and then they want to terminate. And I don't know about other countries. I haven't been outside India for nearly 4 years now. But in India, I do believe it is illegal to do the TOP medication online, because the online platforms, I do tell me that I'm not supposed to, and I do not therefore give any online prescriptions. I do tell them that they need to sign a form called Form C and take the prescription in person. And then they go, oh, okay, and put the phone down. So that is how my telecommunication with TOP patients usually goes. If I do about 20, only one of them comes to me for a prescription and sign the consent form. The other 19, what they're doing, I really don't know. I would like comment from my fellow gynecologists regarding this. If any of you actually think it is okay to do an online prescription, or is it actually really illegal in India? I don't know. I don't do them. But what I'm doing these days is doing telecommunications for people who took abortion pills, just like that. The medical shop guy gave, or the neighbor auntie suggested some tablet and whatever. And 15 days, 20 days later, they're still bleeding. And then they take a consultation to ask if anything can be done at that stage, or if they need a scan, or what's going wrong. So I do realize a lot of people are just buying these tablets over the counter and taking them, and God knows what's happening to them afterwards. And I personally think actually if Indian government allowed us to do online prescription for termination of pregnancy, of course, after seeing a valid proof that they are still less than 8-10 weeks pregnant, the pregnancy is intrauterine, and so on, the precautions what we normally take, maybe it is better to legalize it and give it to them rather than allow them to take over the counter from a medical shop person who probably is not even holding a pharmacy degree. That's my personal opinion, and I don't know what my fellow gynecologists think about it, but a lot of terminations have been happening illegally in the last few months. The other day, I had an encounter with a lady who said, how do you expect me to come to the hospital and take a prescription in lockdown? Then I said, look, this is the rule. I can't change the rule. And she said, how can you be so brutal and not understanding and so rigid? And then I said, I'm really sorry, I'm helpless. Do come, I'll send you an appointment. The police won't stop you. Please come and collect your prescription. And they said, don't you feel shameless for doing this to me during COVID times? And you think, what did this woman do? You know, knowing it's COVID times, why did she take a risk and get pregnant and now blame the doctors for being so rigid? So people, when they are in a distressed mode, they don't really think that what they have done is probably what they should not have done. But we are here to help, and I would love to help these people if I possibly can. But sometimes the rules do make it difficult for these people during pandemic situation. Urinary tract infection in COVID times, you might think, what has COVID got to do with UTI? UTI can happen at any time. Obviously, most UTIs are preceded by sexual activity. I still will not blame the pandemic for increased sexual activity and increased UTI. If people want to have sex, they have sex, pandemic or no pandemic, that's not our business. But what really worries me, what makes me upset is when people take a consultation for UTI and then you ask, was it preceded by sexual intercourse? No. Was it preceded by a very long journey where you held on to urine for a long time? The answer is no. But then they say, we sit in meetings for hours and hours and don't take a break. And you think, what's wrong with you people? These are all IT software professionals. They don't want to take a break from their meetings to go to the toilet. And you think, why do people do this? They're like, no, we're not expected to leave a meeting. So we just sit there holding on to urine for an hour, 2 hours, 3 hours. And I think that's what caused my UTI. And I think people need to understand that body functions need to be done at the correct times. But did they not do it when there was no COVID? I don't know, but I see this a lot in the IT professionals. And what's even more worrying is someone comes to you with a UTI and you empirically treat them with nitrofurantoin or ciprofloxacin majority of the times, or whatever your favorite antibiotic is. But what if that's not the correct antibiotic for them? What if actually, if you did a urine microscopy, of course, a urine microscopy will not tell you what antibiotic to treat them with, but it'll tell you the degree of infection, the number of pus cells, the presence of nitrites, the presence of protein in the blood will give you an indication. And what if you actually did a culture and treated her accordingly, and in the meantime treated her symptoms with citralco or something? These days you ask people to go give a urine sample, they won't. They will not. They'll just take another teleconsultation from another doctor who will give them antibiotics, but they're not prepared to go take that urine sample for culture. So by treating women empirically again and again, are we increasing the risk of antibiotic resistant bacteria, especially in diabetics and older women? I hesitate to just empirically give them something, because by giving them something and making them antibiotic resistant, we're just increasing the problem. We're just making it more difficult for them to get rid of their UTIs. And I don't do much obstetrics. In fact, I only do obstetrics in teleconsults when people ask me for preconception counseling and so on. But antenatal, intrapartum, and postpartum care has significantly gone down in COVID times. But one thing I felt is when someone is less than, say, 8 weeks pregnant, they've just fallen pregnant and they've called you for what to do. I'm pregnant, what medicines to take, what food to eat, what to avoid, what not to do, what to do. That bit can be done telemedicine. Because actually, by examining a woman who is less than 8 weeks pregnant, we don't achieve anything. In fact, we don't even probably need to examine them at that stage. And I felt this is one stage in pregnancy where you could actually do a teleconsultation even when there is no pandemic. And then another time in the pregnancy period where you could do this is in the postnatal phase, where the mother is doing well, she's feeding the baby, she just wants you to find out if she's feeding the baby correctly, the breast position, the nipple sucking, the latching is happening correctly or not. This is again something you could do in a video consultation rather than bring that postnatal mother and the child all the way to your hospital. So there are certain things we could actually do telemedicine even when there is no pandemic. That's one thing we discovered. What about fertility treatment? I don't think any fertility doctor is happy or has been happy during this pandemic. I think it's a big loss to them in many ways, because what fertility treatment can you do when the patient can't come to the clinic at regular intervals? So it's abysmal. The fertility treatment has gone down significantly. And unfortunately, unlike the weight loss in PCOD, there is not much you can do to a subfertility patient when she's at home and you're at the other end of a telephone on this side without being able to meet the patient. And for fertility treatments, time is essence. These women are getting older by the day. Their ovarian reserve is going down by the minute. Their AMH levels are going down. And whatever caused their subfertility, the PCOD or endometriosis or whatever it is only going to get worse with them sat at home. So absolutely not much fertility treatment has been happening. And this is a big loss to some people, to some doctors, and mainly to the couple. Maybe some couple have lost that window of opportunity and they might never be able to get pregnant once this pandemic's done, because so many things have changed about in the last 18 months. What about cancers? My practice, my gynecological cancer practice has gone down by nearly 80%. If someone asked me how my practice is doing or how my practice has been in the last 18 months, I will literally feel like crying. It's gone down to 20% of what it had been. So has cancer taken a break? Has cancer stopped happening in the pandemic? Cancer decided to go on a break? Obviously, it's not. So what's happening to these cancer patients? What are they doing at home? How are they managing? Are they just getting worse and worse and dying at home without ever seeking help? And that is the case. That is what is happening. People who are supposed to have surgery are not coming for surgery. People who are supposed to be taking chemo have stopped taking chemo. The radiation treatments have stopped. The only people who are actually coming to our hospital currently are the ones who paid for the treatment ahead. This sounds awful, but people who paid for the entire, these are packages. You take radiation, you have 30 sessions of radiation. So you pay at the beginning for all the 30 sessions. So they come. Lockdown, no lockdown, corona, whatever, they will still come on time and have their radiation sessions because they've already paid for them. But if it is a kind of cancer treatment where you pay per chemotherapy, you come for chemotherapy every 3 weeks and then you pay each time you come, you pay. these people have almost 90% of them have stopped coming because they haven't made that payment commitment. Obviously, you pay for surgery after you've finished your surgery, and the day you go home, you pay your final bill. 80 to 90% of patients are not coming for surgery anymore. So the only thing that will bring the cancer patients back to their treatment schedule is if they have paid upfront. It's honestly come down to that, and it's very shocking and worrying where all these cancer patients are going. And the only cancer specialty in our hospital which hasn't gone down at all, the same number of patients have come even during the pandemic compared to before the pandemic, is childhood cancers. Again, that tells you that if your child has cancer, pandemic or no pandemic, lockdown or no lockdown, you will bring that child for treatment. But if it is an adult cancer, especially if it is a cancer of the elderly people, they're not coming. Are they not coming, or are they not being brought to the hospital is a different thing. And a lot of my cancer patients are 60 plus. Obviously, gynecological cancers happen to elderly women. And when you ask them, why didn't you come for chemo? Why didn't you come for a follow-up? They're like, it's not that we don't want to come, but someone needs to bring us. My daughter or my son or someone needs to bring us. And they are frightened of getting corona if they bring us to the hospital. Who do you blame in this scenario? Do you blame her son or daughter? It is true that, yes, if they put themselves at risk of corona, they might die, their children might be left orphaned and blah, blah, blah. So it's so wrong to start judging people. It's so wrong to draw ethical issues out of this scenario, but that's exactly what's happening, that the elderly patients are not being brought to the hospital by their family members due to fear of corona to the elderly person and also to themselves. So a significant drop in cancer care. And now if you think about it, is there any cancer which I can treat at home through a teleconsultation? And unfortunately, no, I cannot. There is no cancer treatment which can happen at home through a telephone, through a tablet. So unfortunately, these patients do have to come to the hospital and they're not able to. What about those people who still manage to come to the hospital? If any cancer patient is COVID positive, we operate on them on the 18th day after the positive result, provided they are asymptomatic. If they've still got very bad pair of lungs, obviously we're not going to operate. If there's any procedure which we can done under spinal anesthesia without needing general anesthesia, we're doing it under spinal anesthesia. And if there is, obviously the theater we use for cancer patients is dedicated to cancer patients, so we don't put any infected cases there. And obviously we maintain negative pressure, and the airflow in the theater and all is monitored in such a way that the risk of infection is low. Only today we had an ICMR guideline saying if someone is COVID positive, postpone surgery in them for 6 weeks. But obviously I can't postpone cancer surgery in a COVID positive patient for 6 weeks. So if the patient is well and recovered from COVID, on the 18th day, we operate on them and we take all precautions. And we also have to realize that the cancer patients who are already immunosuppressed are at a much higher risk of getting COVID compared to a non-cancer patient. So, it's a double-edged sword here. What about those people who regularly come for an annual health checkup? My pap smear was due last April. It hasn't happened since. And similarly, mammograms, every 2 years you want 45 pluses to undergo mammograms. I don't know how many of you are due for a pap and a mammogram and haven't had it done because the pandemic made many screening clinics close. Our health checkup area was teeming with people every day before the pandemic, and now that whole department is shut almost on a daily basis because people don't come for health checkups during lockdowns and pandemics. And it's been going on for almost a year and a half now, for 1 year, 15, 16 months. Pap smears, ultrasound scans, cholesterol tests, blood tests, urine tests, the routine sugar tests. What's happening to all these health problems? Are all these health problems just taken a backseat or have stopped happening because of the pandemic? Not really, but we are not checking them, so we don't know what's happening with them. All these people will come back to us once the pandemic finishes, if the pandemic finishes, with much worse chronic illnesses. Of course, we can still do these. There are a lot of people who are getting blood tests done at home, through labs, through diagnostic centers where they go home and do the blood tests. And these days they're uploading the results. But obviously you can't do PAPs and mammos and ultrasound scans at home. Once in a while, a menopausal lady used to come to discuss her hot flushes, to discuss her postmenopausal health, to discuss her inability to sleep properly, the mood swings. None of that is happening these days. Through the telecommunication, only those appointments happen which are mandatory, where there's heavy bleeding or the period hasn't come or you want to terminate your pregnancy or something serious. Nobody takes a teleconsultation to discuss uh, mood, their hot flushes or mood swings or something like that. All these people are silently sat at home going through their menopause, and in addition to everything else that's happening in the pandemic. One thing that I noticed, the whole world has noticed, and I'm sure you all have noticed, is periods have changed in COVID positive patients. A lot of patients are asking, why is my period different? I had COVID last month or 2 months before. Either the period is too heavy or the period is late and too light. But what most people complain of is big clots being passed during the period. And initially, I thought I didn't give much importance to this. I thought maybe it's not the COVID, maybe a new onset of thyroid problem, or maybe it's too much food. Recovering from COVID, people eat a lot, and that's making them obese. And then is that doing something? But then I've figured out that about 25% of people who had COVID will have a different period for 1 or 2 months. Some people say when they're getting a period, they're also getting the other symptoms of COVID, like fatigue, tiredness, and some people even say they even having breathlessness at the period time. A lot of people have said this to me. Then I went and looked up in the literature, and across the globe, there are more than 150 papers which are telling us that post COVID periods change. Why exactly do periods change? What's happening? Why is this happening? We think the virus, in addition to everything it's affecting from head to toe, is also affecting the ovary. That is one theory, that the COVID affects the ovarian function. And then there are people who have questioned, if the COVID virus spoils your ovary, does that mean it's going to spoil your fertility in future? And I'm sure very soon someone will say, will that mean you're at increased risk of ovarian cancer in future? So God knows how far this will go. But it is true that if you have COVID positive patients and they're asking you about their altered periods, do tell them that this is a worldwide phenomenon, but it will get better and it will improve. And probably you could electively tell if any of your gynecological patients have been COVID positive, that if they notice anything different about their periods, not to panic. This is an observed phenomenon and it will get better. And then there is another theory which tells that probably COVID causes stress, and stress we know does alter hypothalamic pituitary ovarian axis. But some of my patients who I asked, who called me to find out if COVID does indeed make a difference to their periods, when I checked with them and I said, were you extremely stressed out? Were you admitted to the hospital? And they were like, I barely had any symptoms. It was very mild. I just had a cold and cough. I recovered very well, but now my period is delayed, or it's very heavy, or there are lots of clots. So I don't think stress actually is the only reason why this is happening, because some people have had very mild COVID and still their period has been affected. What else does COVID do? If you get COVID, what other gynecological problems can it cause? Well, it's caused increased UTI, we noticed, and that is probably because it inflames everything from head to toe, including the urinary tract. But one of the common thing I notice amongst patients who are admitted to the hospital, and also some patients who are being treated at home by doctors who unnecessarily have prescribed too many steroids, is steroids make your sugars go up, and the sugars obviously entertain UTIs and vulvovaginal candidiasis. So one has to be extremely careful before putting a COVID positive patient on steroid. And we have seen this a lot, where unnecessarily a lot of steroids have been given to COVID positive patients. There is a lot of collateral damage due to COVID. COVID not only has spoiled people's lungs and other organs, but the collateral damage will last a very long time. And some of the collateral damage, like death due to cancers, death due to undiagnosed gynecological problems, improper antenatal care, improper intrapartum care. We've had a lot more postnatal issues, a lot more deaths in the infants during the pandemic than we would have seen otherwise. And that is all due to compromised care of pregnant ladies and the management of labor, management of neonates in the pandemic time. And this collateral damage will also worsen people's pre-existing conditions like diabetes, cholesterol, and so on. What can we do? I mean, what can we gynecologists? Is that the whole point of this meeting, not just sit and moan about how Corona has ruined our lives and our professions, but what could we do? Can we do anything about this? And it's just spending maybe 2 to 3 extra minutes with each patient who takes a virtual consultation with you, that this is a time for them to focus on improvising their health. There is no outside food. There is not much pollution if you don't leave your house, and you have plenty of time to sit and exercise. Not sit and exercise, I meant to say stay home and exercise. All that time a person used to spend traveling to and from work and attending various social gatherings and so on, that time can be dedicated to improvising their health and make them feel a little bit bad if they're not already doing this. You're sat at home doing nothing other than whatever you're meant to be doing. So, what have you used this time for? Have you focused on nutrition? Have you focused on weight loss? Have you focused on exercising a bit more? If not, why not? So putting a little bit of force and pressure on people to improvise their health when the opportunity is there. And we are a very broad specialty. There is obstetrics, there's gynecology, there is benign, there is malignant, there is fertility issues, there's menopausal issues, there's menarchal issues, just numerous things we gynecologists deal with and we obstetricians deal with. And the more knowledgeable we are, that gives us a power to be able to deal with any situation. So I think we have to become better at taking history, at trying to differentiate the various different causes of various different problems just by taking a very good history. Previously, we used to bank on examination, we used to bank on scans and hysteroscopies and so on. But these days, we have to do a lot of triage on the phone. And therefore, improving our knowledge about how to differentiate different symptoms and different conditions on the phone by trying to find out how different people present when, how is the spasmodic dysmenorrhea different to congestive dysmenorrhea? Is there any deep dyspareunia? Is there various different things, the color of vaginal discharge? All this will come only when you read and read and read and find out the nitty gritty of various gynecological conditions. And it is up to us to look after our women, because this woman is very important. Even when the pandemic finishes, this woman plays a very vital role in the family and in the society. And losing our women and their health to the pandemic is going to cost us very badly for a very long time. And what does future imply? So even when the pandemic finishes, I would love to say is I just do hope the pandemic finishes soon. When the pandemic finishes, I don't think we should give up on our telemedicine. I think we should continue some of our consultations through telephone, and some follow-up consultations can definitely be done via virtually. Some antenatal appointments can, and some postnatal appointments can be done virtually. Follow-up of people who have undergone gynecological procedures can be done through telephone. And the initial assessment of a woman who wants a TOP can also be done. We can talk to them about contraception. We can talk to them about continuation of pregnancy, ask them why they really want to do the TOP, and then bring them to the clinic. And I think one thing that will make a big difference is if we could do the COVID test, the rapid test, where the result is available immediately. Because so many times, so many of my obstetric colleagues tell me that they have stopped examining pregnant ladies. The pregnant lady sits somewhere else, you sit like 3 meters away from her, and you're doing an obstetric consultation, and you don't want to go close and examine the abdomen and do cervical assessment should the need arise, just because you don't want to get the infection and you don't want to give her the infection. If at all there was a test where you could just do a test, positive people get treated differently in a different locality, negative people get treated normally. So I think we just need more COVID tests, which you could do in your clinical setting with an immediate report, so you can look after women better without the fear of mutual corona transmission. And this I found interesting, and I'm really not sure what to comment. And I would like the audience to share some comments about this, about what is it true that 10% of endometriosis patients have thoracic endometriosis? And is it true that if you have thoracic endometriosis and you get corona, it will be much worse? Because there's a lot of this topic and debate and issue going on in our medical journals that thoracic endometriosis is very common, and if people with thoracic endometriosis get COVID, it will be much worse in them. So I'm intrigued. What if someone has endometriosis? Do 10% of them have it in their chest? And if you know someone has endometriosis, then should you warn them that they should be more careful not to get corona? Because if they do, it will be much worse. I don't know. This whole topic doesn't sound very scientifically based to me, but it's very early. People are just talking about it, and I would like your opinion. And my worst fear about COVID and ONG is what it's done to our trainees. For about 16, 17 months, our trainees have not had much obstetric or benign gynecological experience at all. There has hardly been any hands-on training. And these trainees are going to treat your and my gynecological problems when we become old. Well, not just you and me, they're going to treat a lot more patients in future. And how are they going to get that hands-on training? What can happen? A year and a half of your postgraduate degree, you have not actually touched many patients. And how are you going to learn? How are you going to compensate? And I think it's for us, once this pandemic finishes, we need to focus on our trainees and allow them to do more. Allow them to do more under supervision, because these trainees are our future gynecologists, and we need to invest in them. It's not only just the pandemic has not just ruined our practice and ruined our patients' health, but it has also ruined our trainees' training, and we need to focus on it. And this is where I end, and I'm open to questions.
Thank you, ma'am. Thank you for your excellent presentation, and we are honored and learning to hear you, ma'am. So, if you allow me, then we'll take the questions.
Please, please do.
Yeah, we have one question, ma'am. Does HRT in menopause will do harm, or it is benefit for the patient?
Well, HRT is definitely beneficial if you give it before the age of menopause, which, I mean, if someone's gone through the menopause and they are less than 52, because 52 is the average age of menopause in India, I definitely would recommend HRT, because all the studies which have told us that HRT can cause an effect on breast cancer, can actually do some damage to the heart, were done in postmenopausal women. But all these women were more than 52 years of age when they took HRT, and most of these women were abroad in UK and USA. So if anyone in India asks me if they could take HRT and are less than 52, they went through their menopause before the natural age of menopause, I give them HRT until the age of 52. And and as long as they don't have a personal or a family history of breast cancer, and they don't have a history of DVT or PE, and they don't have gallstones, these are the three contraindications, I do put them on HRT, because obviously it improves their overall health and improves their bone strength, their teeth strength, and the skin and everything about them. So yes, it is safe to give HRT until the age of 52. But after the age of 52, I usually do not recommend HRT unless the woman is okay and you tell her that every 2 years of HRT increases your risk of breast cancer very slightly. From 1 in 10, from 1 in 12, it becomes 1 in 10. And if you're willing to take this risk, I'm happy to give you HRT maybe for maximum 6 to 12 months. And then I do stop the HRT.
Thank you very much, ma'am. And even my interest of question, ma'am, whether estrogen, I mean, have any effect with this immune ET? Because I've a lot of seen some articles saying that estrogen also, I mean, the people who are taking estrogen are more safer than not taking in menopause.
Yes, in fact, this was in one of your slides, Dr. Soman. I did see it. And the reason uh, why COVID is affecting more menopausal women compared to premenopausal is because of the deficiency in estrogen. And the reason PCOD people, there is also another study, a couple of studies actually, which said that women with PCOD are at a higher risk of COVID infection. Again, probably because they're low in their hormones. So estrogen deficiency, I think, post estrogen deficiency, I think, does put you at a higher risk of COVID infection. And estrogen supplementation or having good estrogen levels is good for your immunity. And I don't think it's just COVID. I think anything affects you. You know, you're not, if you're meant to be having estrogen and your estrogen levels are low, I do think it affects your overall health.
Thank you very much, ma'am. Ma'am, there are no questions from the delegates. So if there are any questions, definitely we'll pass it on to you in mail. So you can answer them through the mail.
Sure. Yeah.
So thank you, ma'am. Thank you very much for your valuable time. So we'll look forward for your continuous support for this. So thank you very
Sure.
much, and also thank all the delegates who are participating in this webinar.
Thank you all.
Thank you, ma'am.